Hello, good afternoon, good evening, good morning, depends on where you are connected from. My name is Emmanuel Adigbola, and I'm so excited to welcome all our viewers to today's show. Today, we are going to be discussing one of the very important topics to the art of David Domenico Foundation, especially the host of this show. And of course, she's not alone. I'm not alone. We, as usual, we have our panelists in the house that are going to be, sharing and discussing the topic with you. I'm not going to tell you the topic. I will wait for the host to announce that to you. By the way, I have other panelists right in the studio with me, so I'm going to be bringing them to introduce themselves to you and just to say hello. So let me start with Dr. Agbola Fatiregun. Over to you, sir.
Good afternoon. I'm Dr. Agbola Fatiregun. I've been a physician for about 21 years now, so I'm happy to be here.
Awesome, awesome. Thank you so much. It's always very interesting and nice to have you in the studio. And then we have Dr. Agawa Raso right here. Can you go ahead and say hello to our viewers?
Yes, I'm Dr. Ashwani Agarwal. I'm with Texas Oncology here in Dallas, in practice for over 20 years, busy practice, and I have a number of patients with colon cancer. I keep myself very current with the treatment and management and of colon cancer because this is indeed the third most common cancer I see in my practice.
Awesome, awesome. Thank you so much, and thank you for joining us today. And also in the studio today, we have with us the representative of David Domenico Foundation in Nigeria. I mean, without him, I doubt if our foundation will be able to do what is doing. I mean, what she's doing right in Nigeria. So join me to welcome Dr. Bright Gochuko as he says hello to our viewers.
Thank you, Dr. Emmanuel. Bright Ugochukwu is my name. I represent David Domenico Foundation here in Nigeria. Thank you.
Awesome, awesome. Good to see you. And of course, I have my co-host also with me right in the studio, Mr. Alex. Go ahead and say hello to our viewers.
Hello, everybody. My name is Alex Mahiri. I'm sure you know what I do already. I co-host with him and I also run the activities of David Domenico Foundation here in the United States. Thank you.
Awesome, awesome, awesome. And of course, with standing ovation while we remain seated, join me even as we welcome the host of Keyna Health Show as she introduces today's topic and also say hello to all our viewers. Over to you, Dr. Keyna.
Thank you. Thank you for that introduction. Thank you to our panelists. Hello, our viewers from all over the world. Thank you for joining today's show. Today's topic is a topic that is very dear to my heart, which was the basis of our David Domenico Foundation, which we established over 6 years ago. The topic is part of our efforts to join others to memorialize March as a Colorectal Cancer Awareness Month. You may recall just last month, we also joined the whole world in celebrating World Cancer Day with its numerous activities, which is ever ongoing. Colorectal Cancer Awareness Month is observed every March to create awareness on the dangers of colon cancer and mobilize individuals, groups, corporate bodies, government to unite and fight the scourge of colon cancer and its devastating impact on mankind. Colon cancer, which was thought to be an older person's disease, is now ravaging the younger adults, and most of the time is identified at late stage. You all remember late Chadwick Boseman was among a growing number of young adults to be diagnosed with colon cancer. And data shows that colon cancer diagnosis is going to be increased by 2.7%, and the date is going to continue to rise. American Cancer Society estimates that 12% of all new colon cancer cases, which is approximately 18,000 people, will be diagnosed in patients younger than 50 years of age. And by 2030, 10% of colon cancers and 22% of rectal cancer diagnoses in the US are expected to be in patients younger than 50 years of age. This is very alarming and it calls for serious actions. This forecast is a significant jump from 10 years ago, which was mere 4% for colon cancer diagnosis and 9% of rectal cancer. So today's show is very important, very critical. And I'm happy today we also have a pediatrician amongst us who, with Dr. Agrawal and other healthcare providers, will shed some light into these alarming statistics and give us some direction on how to keep our families safe and the younger generation from succumbing to this colon cancer. So stay tight wherever you are and just enjoy the show.
Awesome. What an opening remark. All right. So over to you, Mr. Alex, even as a Padu the Keno of this show today. Over to you.
Yeah, Dr. Agrawal, let's go right away. Can you let our people who are watching us, who are participating in the program, can you give them a little bit explanation of what you mean by colon cancer, colorectal cancer, and how to watch it?
So, colorectal cancer, these are the cancers, or it is uncontrolled growth of glandular epithelium or glands, which are located in the whole of colon and the rectum. There is a little bit of difference between the colon and the rectal cancer. I'm going to talk about it in a minute. But in general, this colon cancer, they arise from glandular epithelium, and there is an uncontrolled growth of these glandular cells, and which start eventually penetrating all the layers of the colon, and then they start spreading to the lymph nodes and then to other organs. This is the general history of this colon cancer, how it progresses from the colon stage into the perirectal tissue, pericolonic tissue, and into the other organs. In the rectum, because it is a little bit on the lower side, on the left side, just before it goes into the anal canal, the peritoneal deflection happens right above the rectum, where the rectum starts. So the protection mechanism from the spread from the rectal cancer is different, and it tends to spread much faster to the lymph nodes locally and little bit on the inguinal side from the rectum rather than into the peritoneal cavity. Peritoneum around the colon protects somewhat the spread of the colon cancer from rest of the colon. So rectal cancer behave a little bit different in the sense that they spread in a different way, and thus the treatment is also different. But in general, it is the uncontrolled growth of these glandular cells. Should I go over the staging part right now, or of the colon cancer, or we're gonna talk about it in?
Okay.
We will get back to it, Dr. Agrawal.
Okay.
Okay, over to Mr. Alex.
All right. So now we are going to. Nigeria is one of the countries where cancer, healthcare and cancer is very minimal, if not non-existent. And we have Bright from Nigeria. Bright, how do you people, like you did World Cancer Day, and this month we are celebrating, observing March colorectal cancer. So what experience do you have? What do people react about cancer? Do they believe it is real, or are they looking at it still from the angle of is a white man's disease?
Thank you very much, Mr. Alex. Here in Nigeria, and David Medical Foundation has tried to raise the awareness that cancer is real. So whether you like, you don't have a choice to believe. And we only believe it is real when you go to hospital or when the thing affects somebody who is very close to you. So we have a lot of ideologies here, and unfortunately, a greater percentage of those ideologies tend to cover the real aspect on ground. And we are trying very much possible to make sure that the real situation is being presented to people, which is early screening, prevention, dieting, and all these guidelines to control the risk factors on cancer. So tell you truthfully, people really don't believe in it unless it happens to somebody who is very close to them. That's what the situation is on ground here. Thank you.
Yeah, but during your screening exercises and the rest, how many people have you been able to identify? Were you able to identify people who had it? And if you did, what steps did you take in terms of making referrals? So what are can you give us a little bit of your experience in terms of practicality?
Okay, thank you very much. Let me recognize quickly from October to now, which is not a very long period of time. October last year, we screened over 400 women for mammogram, where we are trying to prevent breast cancer. Because every October, the world celebrates is a breast cancer month. In those number of people who were able to refer about 25 women with serious indication on their results, which we may not really present publicly here. We referred about 25 women to the oncologist for further investigation. And, most times when you have some of these results, you look at the patient and look at what is really happening. You don't know whether to disclose or not. The person will be asking you, what is wrong? What is wrong? What is wrong? You will now stop at, please. The oncology will tell you better. So those results are very scary, and we don't want to be getting that kind of number. But because we don't have the funds, we have limited funds here in Nigeria. David Medical Foundation is being sponsored solely by the Chief Executive Officer, Dr. Keyna from our pocket. So, but if we have a lot of people who can say do this, I think the number will increase. Because if you screen over 400 and you have about 25 with such a very dangerous result, something is wrong. Then we move over to the February 4th, where the Union for International Cancer Control, alongside with the United Nations, celebrates World Cancer Day. Not just one particular type of cancer this time around. We screened about 115 men for prostate. We screened about 118 or 19 women and men for colorectal cancer and other forms. I bet you, among the 117 men that that presented themselves for the prostate screening, about 42 or 43 are currently on their biopsies. They will refer them for qualitative biopsy screening. That is to show you that it is not a child's play for now. Then we are here again in March, where we celebrate also the Colorectal Cancer Awareness Month. Because of the disturbing numbers we have got in October and in February, the Chief Executive Officer of the Foundation has deemed it fit for us to move into March with aggressive campaign again, whereby we have stipulated what we want to do this March in Imo State and beyond, because of what the the statistics we have got in March and in February this year. Here in Nigeria and here in Imo State, we have 27 local councils here, local governments making up the state. And we want to create this awareness in all the secondary schools in Imo State here. Each of these local governments has not less than 50 secondary schools. And you can imagine what it will cost you to run this awareness in 50 secondary schools, because we are organized, we are looking at a quiz competition to test the level of awareness in young people, because these current statistics begins to expose us that not just from 40 years benchmark for either colorectal cancer or any form of cancer anymore, but people under this age are now beginning to face the music. So we have decided to move into aggressive campaign and screening into secondary schools in Imo State. And this is one of the activities we have lined up to mark this year's our Colorectal Cancer Awareness Month as a foundation. We have also decided to screen the staff of this secondary school, these secondary schools. If the government cannot do, we want to see what we can do. It's a hell lot of money to go through more than 27 local government, or among 27 local government, with more than 50 secondary schools in each of them. So that is what poised us. The statistics we got in March and February and October has poised us to move into this month with a lot of aggression. Thank you.
I think that sounds a right.
Okay, right. Thank you very much.
Mr. Alex, let me, I know we've got a lot of things to cover, but I wanted to engage Dr. Fatiregu a little bit. Dr. Fatiregu, with all these statistics, I know you are a pediatrician. What is your experience with colon cancer in your practice with the younger generation? And I know there is an association of pediatricians. Are they doing anything to see what needs to be done as the younger generation face colorectal cancer, even in their early 20s? Can you shed some light on from a pediatric point of view?
So, I mean, fortunately, colorectal cancer doesn't really hit our population all that much, but it's important for this population of patients to kind of develop good eating habits. So I always say an ounce of prevention is worth a pound of cure. So one of the risk factors for colon cancer in general is what you eat. What you put in your body is a vessel. So you have to know what you put in your body. So you have to steer away from high processed foods. Try to incorporate high fiber diets. Try to stay away from fatty foods. Anything that is creamy, really tasty, is usually on one of the lists of bad things in terms of putting into your body. So that, along with keeping watching your BMI, meaning watching your weight, and those things, to be honest, obesity is a huge pediatric issue. So even I have some of my own patients that they'll present at 6-9 months and their BMIs are off the charts. Here in Western Europe and in the United States, things are nutrients are fairly plentiful. We have the other issue. We don't have the malnutrition. We have the obesity issues. But trying to encourage exercise at a young age, I try to impress on my parents and my patients. We can exercise at least an hour, 4 or 5 times a week. That would also help reduce the risk of developing colon cancer and other diseases later on. A lot of times parents will invest in a lot of huge expenditures of gym memberships, or they'll buy these whether it be the big name bicycles or equipment. They end up in their houses and without being used at all. A better way is to try to incorporate exercise in your everyday lifestyle. So you don't have to be in the gym, but if we can take the elevator, take the stairs instead of the elevator, instead of the escalator when you're at work. Males especially, we get excited when we score a parking space right next to where we need to go. But actually, if you can take the if you can park a little bit further from your point of entry and use that to walk, it also incorporates some more exercise. So from a pediatric standpoint, it's more about prevention in terms of increasing exercise, avoiding high-processed foods, encouraging high-fiber diets, brown rice instead of white rice, whole grain bread, things like that. And studies show that if children, even as young as 5, 6, 7, develop healthy diet choices, then have healthy diet, they'll also keep those healthy diet choices as they become adults and adolescents. And that'll kind of help minimize their risk as well.
Thank you. I have a follow-up question on that. How do you advise parents who would say, my kids are young, they can take as much sugar as they want, and they can drink fruit juices, it doesn't hurt them, their body will get rid of it before they get old? How would you advise parents on fruit juice intake and sugary intake?
Yeah, it's a common question, even as kids as young as 6 months, to be honest. When kids start to take solids and move away from formula, a lot of parents believe that they have to give juice because it balances the food. That's actually incorrect. All fruit juice is processed sugar. It's empty calories. Doesn't add much nutritional value at all. It's actually very hard to burn off. So a lot of times I'll meet parents that their kids are doing most of the right things. They're in football, so they're exercising 4 to 6 times a week because of the multiple practices and then the actual competitive game. But they're drinking tons. They see the commercials. They see their favorite heroes drinking Gatorade or Powerade and whatnot, and they don't think even Gatorade is high in sugar, but it is. Really, we try to minimize juice for your toddlers to maybe 4 ounces a day after they turn 12 months of age. The older ones, we may say 6 to 8 ounces maximum, just because once, if you go to any restaurant, especially here in Texas, the serving sizes for juice especially, they give you these like almost buckets worth of servings. And that's, you can't, then kids are kids, so they're gonna push the envelope. So they're gonna do that 2 or 3 times a day. So if you add that up, that's a lot of calories. There's like about 200 calories in one serving. They can do it 3 or 4 times. That's 800 calories right there. And then that doesn't even inspiration to eat in terms of food from breakfast, lunch, and dinner, snacks. So from a pediatrician standpoint, we try to minimize all the empty calorie drinks, maybe at most 6 ounces a day, and try to encourage water.
Thank you. Next, Radex, go ahead.
Okay, Dr. Agawad, let's get into how do you identify colon cancer patients and rectal cancer patients? What are the things you see? What signs do you see? So before you go out to chase it.
Rectal cancer can present with a number of ways. One of the most common ways of presentation for colorectal cancer is change in bowel habits. That means they're either developing constipation or diarrhea. So that needs to be investigated. Then the second most common is abdominal pain and discomfort. The third most common presentation is bleeding, or what we call in medical language as hematochezia. and this is more common with the rectal cancer. We can see more fresh bleeding, but with the colon cancer, we can see the blood mixed with stools. And most of the time, actually, a lot of times, especially in US or the Western countries, we identify the patient because they develop iron deficiency anemia over time, and this is from the slow bleeding. And they go to the doctor, and they see, and they're totally asymptomatic. And they go to the doctor and for the routine checkup, and first thing they find is iron deficiency anemia. Uh, and We take that iron deficiency anemia, especially in men, very seriously, because the cause of iron deficiency anemia in men is most of the time is blood loss from somewhere, and cancer and the rectal cancer can cause this slow bleeding over time and cause anemia. Some patients we have found even by imaging, they go for PET scan for a totally different reason. And I see a lot of cancer for other things, and I do a lot of PET scans on patients just for a routine follow-up for mm, different cancers. And we end up seeing something that lights up in the colon. And you further investigate, and you can see some colon cancer. Um, One more point I wanted to add about epidemiology. I'm originally from India, and I used to be an oncologic surgeon in India for a couple of years before I migrated here. And as a surgeon and an oncology, I barely saw colon cancer actually. There was hardly any colon cancer. As soon as I came to this country, the colon cancer was rampant. In fact, it is the second most common malignancy in US in men. Third most common malignancy in US in men, and second most common malignancy in females in Western world. And this has to do with some of the factors. The most important factors is uh, the diet, and they have very low fiber diet, and that has been implicated in the development of this colon cancer. Whole of the highest incidence of colon cancer we see in all the Western countries, including USA, Europe, Australia, New Zealand. These are the highest country, and the lowest incidence we see, fortunately for one thing at least, is African nations and Southeast Asia. We see the lowest incidence of patient because I think one of the reasons is it's all high fiber diet that is probably protective in this population.
Awesome,
Yeah.
awesome. Yeah, before we continue, Mr. Alex, before we continue, there's this story that I kind of would like us to share with our audience, and that is Lisa's story. She's a cancer survivor.
I'm Melissa Murphy, and I was diagnosed with colorectal cancer when I was 36. I was shocked. I couldn't believe I had cancer. I felt fine. I didn't feel sick, and I thought, surely I can't have cancer. I'm an optimistic person, so initially my fear wasn't death. My fear was my quality of life. What is my life going to be like? Is it going to interrupt my daily routine? What are treatments going to be like? Will I be able to continue to work? Will I be able to have children? I knew that one of the side effects from, colorectal cancer was infertility. So fortunately at the time I had contacts in the reproductive world and was able to get some surgeries, had my ovary removed, that type of thing, to be able to hopefully be able to have children in the future. Once I accepted the fact that I did have cancer, I needed to get the best team together to be able to fight this cancer, and that's essentially what I did. I'm currently in pharmaceutical sales, so I have a lot of access to local physicians, and I did get a couple different opinions, and as I was asking physicians and coworkers, in the area, there was one name that kept on coming up, and that was Dr. Fleshman's name. And when I made the appointment and met with Dr. Fleshman, he was excellent explaining the procedure and also gave the option to do this procedure laparoscopically. It was also my understanding that that Dr. Fleshman and Siteman was the only hospital in the area that did offer this procedure. So I was thrilled to be able to have the opportunity to have Dr. Fleshman perform this procedure laparoscopically. The recovery.
Awesome, awesome. So just to let us know that what we are talking about is not theory, that is real. There are a lot of stories. In fact, today we are expecting one of the cancer survivor from Nigeria to actually share his story. I'm surprised that he's not here. So over to you, Mr. Alex.
Yeah, Dr. Fateri, like Keyna said, a lot of victims of colon cancer are now people in the younger age. And I know in your practice, you must have been meeting some of these cases. So how do you identify them, and what do you do when you see them? And secondly, how does it affect fertility? People who had it and survived, and they are wanting to come back to you in your area of specialization. How do you manage the cases? What way do you normally try to marry them? So can we have share your experience with you?
Sure. So again, in the pediatric population, meaning in under 18, maybe in my Nigerian colleagues, maybe they extend their practice past 18 years of age, but here in the United States, you're not going to see very many, maybe one in a career, of people with colorectal cancer under the age of 19. You have other GI issues. Dr. Agro is aware of. Sometimes you have to have a risk factor for inflammatory bowel disease. That might be a risk factor later on. Things like Crohn's disease and ulcerative colitis. But usually kids under 20, at least in my neck of the woods, usually don't develop colorectal cancer. But it's still important to introduce concepts about the right things, and increasing fiber, increasing fruits and vegetables, avoiding processed foods, exercising, watching your BMI. All those are principles that we use in pediatrics, that if we can impress that upon parents and my patients, they should have better outcomes later on. One of the key things that also is a risk factor is lack of access to care. So one of the issues that kind of puts Americans at colorectal cancer is that, one, they don't see the doctor as often as they should. They should have yearly checkups. The way we screen for colorectal cancer, it's controversial between 45 and 50, and Dr. Agro will talk about that. But at the very least, as adults, we should have the certain fecal testing. And then depending on who you read, who you follow, by age 45 or 50, well, probably younger if you have a family history of colorectal cancer. But even if there's no history, it's important to get scoped. Colonoscopy done at age 45 for both sexes. Again, it's the top 3 colorectal cancer, the death and incidence for both men and women. So that's important. In terms of the other question about fertility, again, that's something I ask one of my adult or OBGYN colleagues.
Okay. Dr. Agbawa, let us look at when you identify a cancer patient, what do you normally do? And what are the areas they can get resources? Because a lot of people don't even know what to do. Immediately they are affected. So can you tell us what you normally do and how to help them identify resources?
Yeah. Did you get the question,
Did
Doctor?
you get my question, Dr. Agbawa?
Oh, this is for me?
Yes.
Can you repeat the question?
The question I'm saying that most of the time, people who get infected, who become victims of cancer, don't even know what to do. They get confused. First of all, they don't know what to do. They don't know where to get the resources. They start making calls. they start panicking. So how do you handle such cases? And can you let us know where resources can be got?
Yes. First of all, I want to touch a little bit about, for 1 minute, about the familial cancer, which Dr. Agboola was talking about. There are a number of familial syndromes we should be aware of in colorectal cancer, and these are the patients who can present with younger age. But I have not seen any patient with colon cancer in last 25 years of practice, less than 20 years. Fortunately, the youngest I've seen is about like a 22 years old kid with colon cancer. But there is a syndrome called familial adiposis syndrome. In these patients, they have like the whole colon is full of polyps, and they need to be monitored very carefully. Then there is another syndrome called Lynch syndrome. Basically, it's an autosomal dominant disorder, and it is implicated. It's actually present much more common than we normally know. It's about 3% of the colon cancers have Lynch syndrome. What that means is there is a mutation in one of the genes, and that can affect actually other, and these patients can have other kinds of cancer, especially the uterine cancer also. So these are some of the familial syndromes where the patients need to be screened much earlier than usual, 45 or 50 years of age, because they can develop colon cancer at a much earlier stage in life. And then Dr. Agboola already said that ulcerative colitis and Crohn's disease is already a risk of factor. Now, once you have colon cancer diagnosis, uh, let me tell you one thing: there is no need to panic. This is one of the most curable malignancies even today. Uh, eh, Once you're diagnosed, you need to see a surgeon right away, a medical oncologist or a surgical oncologist right away. And once the diagnosis is made, which is most of the time a histopathologic diagnosis, that means they've gone through the colonoscopy, they've done the biopsy, and the histopathology shows that this is adenocarcinoma, colon cancer, or rectal cancer. Then the next step is the staging of the cancer, where we do the CT scans of chest, abdomen, and pelvis and make sure that it has not spread beyond the colon, and basically the stage of the cancer. And once you have the stage of the cancer, the next thing is the treatment. And just to briefly go over the stages of the cancer, the colon cancer, like most other cancers, is stage four, in 4 stages. Is stage 1 is limited to the internal mucosa of the colon, below the muscularis mucosa. To be a little bit more technical for some people who are in the medical fields listening to this talk. The second one is called stage 2, where it's gone beyond the muscularis mucosa into the perirectal tissue, but has not involved the lymph nodes. Once it has involved the lymph node, it becomes stage 3. And beyond the lymph nodes, if it has gone to other organs like liver or the peritoneum or lungs, it becomes stage 4. Up to stage 3, we can cure almost 80, actually stage 1 and 2, we can cure almost 90 to 95% patients just by surgery alone. So there is absolutely no need to panic. This is a very curable disease, especially in the stage 1 and 2. Even in the stage 3, we can cure almost 80 to 85% of the people with surgery and chemotherapy. That number has gone up to almost 90%. But once it's gone to stage 4, then the prognosis becomes a little more poor. But still, even in stage 4, these patients, the median survival has gone up to like, it's still not a death sentence or it's not a terminal illness, because it has become more of a chronic disease with number of treatments we are giving. And median survival has gone beyond like 3 years these days. So the first thing is, as soon as you get the diagnosis or you have suspicion of a diagnosis, you need to see a medical oncologist and a surgical oncologist in your community.
Awesome.
Just to piggyback on that, I mean, that's the key point about access to care. Colon cancer can be devastating, but if it's picked up on time, it's very highly treatable. Problem goes when people go without health care for several years, and then then colon cancer is found in its later stages. That's when it becomes life-threatening. So, I would recommend anyone who's listening, primary care provider yearly, get the right test done, go over family history if your doctor. And don't shy away. Some people are, especially men, um, find it a little bit intimidating to have that procedure done, whether it be the sigmoidoscopy or the colonoscopy. But it's important to our daughters' weddings. If you want to be around our sons, how to tie a tie, how to change a tire, how to court women. We want to be alive. Those are the greatest things we want to do with our kids. So we have to be around in order to do those things. Only get screened.
Thank you so much. I don't know if we have dealt with question number 5 on our synopsis for today, and that is how can one avoid or prevent the colorectal cancer scourge? I don't think we've dealt with that. So how can one avoid or prevent that? And if we could also just match that with what are the advantages of early detection? Because like yesterday, we actually went to see one of our family friend, and this man was sharing with us how he actually went to for his annual uh, medical exams, and they just discover, I mean, very early stage that his PSA was higher than 1.0. And of course, actually, according to him, like 3 years ago, it was 1.5. 3 years ago, it was like 2.0. Then late last year, it was like a 4.0. And they just say, you know what? There's need for an urgent surgery. So I guess I'm combining two questions now. So what are the advantages of early detection and screening for colorectal cancer? And how can one avoid or prevent the colorectal cancer scourge? So 2 questions in one. Dr. Gerald.
Yes. So I mean, this is one cancer. Like I said earlier, is screening is very, very important, because if you can diagnose the cancer in up to stage 1, 2, or 3, it is almost 90% curable. Curable means this cancer will not come back. So there are a number of ways we do the screening here in US, and the simplest way to do screening all over the world, which I used to do in India, is a rectal examination and do a fecal occult blood in the stools. If you see blood in stool, you have to look for colon cancer. You have to do a colonoscopy and go further. There is another test. It is available here. Those who don't want to undergo colonoscopy is called Cologuard. They collect a stool sample and look for uh, cancer cells in that small sample, or DNA of the cancer cells in the small sample, and they're able to detect something. Is not the most sensitive or the specific test, but it gives a very good idea, better than the fecal occult blood for the early screening. And then at the age of, right now, the recommendation is to get the first colonoscopy at the age of 50. But like we have talked before in this program, the colon cancer we are seeing in the younger and younger age group. So some people are even recommending colonoscopy at a younger age, maybe starting at about 45. There are other risk factors we also identify with colon cancer, and that may also tip us towards colonoscopy a little bit at a younger age. And some of the risk factors we know is, and some, we've talked about it briefly in this program, is one of the risk factors is obesity. Second is tobacco smoking. Third is high quantities of alcohol consumption, lack of exercise. In prostate cancer patients, use of androgen deprivation therapy has been associated with increased risk of colon cancer. Even cholecystectomy, there is a slightly increased risk of colon cancer in these patients who underwent gallbladder surgeries. So these are some of the things that can be identified, and maybe in these patients we can do the colonoscopy at a much earlier stage. Colonoscopy is widely available, luckily, in our country. There are a lot of gastroenterologists going around with a colonoscope, and they'll do right away. But in other countries, like in India and in African countries, it may not be so readily available. So the easiest thing to do for screening is the stool samples for occult blood.
Now that takes us to how to support cancer patients. A lot of the cancer patients are anxious, they are suffering from anxiety because of what they call remission. The cancer goes into remission. You start rejoicing, before you know it, it comes back again. So they live in fear, they live in anxiety. Is there a way to support? How do you support them? How do you encourage them? How do you make them have and live a normal life? This is open to anybody, two of you, any of you who wants to pick it up.
So we with Texas Oncology, we have a lot of support groups. There are a lot of we give them enough literature that they can join these support groups. When they come to us, our nurses guide them into these support groups. There are a number of internet sites which are very reputable. But some of the things where I recommend my patients to go is go to American Society of Clinical Oncology site, which is a very reputable society, and everything is screened. And then they have chat groups and information about what the follow-up should be in these patients. So I mean, I would recommend people going on. And then there is American Cancer Association also. They have good resources in terms of follow-up, in terms of chat groups and focus groups for colon cancer. There are a lot of resources here at this time. But once someone is diagnosed and cured of cancer by surgery or with chemotherapy, there is a follow-up process we follow. Most of the time, what happens is the recurrence happens within first 2 years. If the patient does not, so in first 2 years, we screen these people much more rigorously. Like every 3 months, we follow them with a tumor marker called CEA, the physical examination, and if there is any suspicion, we go for another colonoscopy or CAT scan. In the first 2 years, every 3 to 4 months, we follow them. After that, the chance of recurrence become smaller and smaller, and then after 5 years, it's almost negligible. So that's what I tell my patients, that once you have reached the 5-year mark, you should not worry about it at all. But still, they need surveillance colonoscopies, and then the GI doctor, they have their own guidelines in that sense how often they should get it.
Okay.
Dr. Agarwal, I have a follow-up question from the discussion about the age at which colonoscopy should be given. American Cancer Society had recommended several years ago that the age be lowered from 50 to 45. And from my experience, I see that many insurance companies are reluctant approving colonoscopy for those age group from 45 years and above. And the way things are going from statistics and experiences, we see that it will be very important if these guidelines are followed, so that we can save more lives if colonoscopies are done at earlier ages.
I totally agree. I mean, these insurance companies, they kind of denied. Some of these patients are justified by telling them these are high risk. I have to write an extra letter to get it approved. But besides colonoscopy, what I'm doing some of these patients is a test called Cologuard. And this is basically taking a huge big stool sample and looking for any DNA evidence of cancer. It is quite sensitive, but it's not specific. If the test comes back positive, then most of the insurance companies will approve a colonoscopy in these patients. But you're so right. I mean, the insurance company, they don't want to pay or for these younger age group. We deal with this every single day in our practice. Their idea is not to pay as much as they can, but our thing is to just help our patients. And I do write these letters showing
And
them there are high risk features that he needs earlier colonoscopy.
right. And thank you. And another thing I have found out, I'm not sure, going through research, many patients that I've run into have had their colonoscopy 10 years and they were told to return 10 years afterwards. Is that still a good guideline? Because we've seen so many patients who had a clear colonoscopy, and by year 5 or year 6 into their 10 year for a repeat colonoscopy, they've come down with stage 2 colon cancer. Have you seen that?
Yes, that's a very good point. Actually, that's very good. You brought it up. Number of my colleagues, they are gastroenterologists, and I ask the same question, like you're asking: is 10 years or 5 years repeat colonoscopy? So what they tell me is, and this I think varies from gastroenterologist to gastroenterologist. Generally, the recommendation is every 5 years for at least 3 times, and after that is 10 years. That's fine. But in the first colonoscopy, if they do not find any polyp at all, do not find like zero polyp, then nothing, then they say 10 years is absolutely fine. And the reason is this: the colon cancer has been the most studied cancer, in the sense it has such a beautiful story, the how it progresses from a small polyp into a larger polyp, into dysplasia, into early carcinoma in situ, into invasive cancer. The story is so compelling and it has been so well studied that if you don't find polyp, and the thing is, it takes average about like maybe from the polyp stage to get to a colon cancer, it takes about 5 to 10 years. So if you have not found any polyp in the colonoscopy, there is no need to repeat another colonoscopy in 5 years. But if they find some polyps, they generally recommend repeating another colonoscopy in 5 years, because the story is very, very, very compelling in terms of the progression from a polyp to a colon cancer. And another thing, what happens is if you do a polypectomy, you take out the polyp and look under the histopathology, and you just find nothing like benign adenoma, and you don't find any evidence of Lynch syndrome or any of those mutations which they can look up in the histopathology, there is no need to do another repeat colonoscopy earlier. But I still recommend getting at least 75 years for at least 2 or 3 times. And then, depending on the results, they can go every 10 years.
Okay.
Yeah, Dr. Fatiregun, let's look at a situation where you get a patient and the person came really for gynecological issue. And in the process, you begin to suspect the person has cancer. How do you manage the situation? Have you had such experience? And if you did, how did you manage the situation?
So we approach everything in medicine with history and physical exam. If you have certain signs and symptoms that point toward a particular cancer, then there's some screening blood tests that you might want to get. Anemia, like the doctor said, a lot of times you'll have iron deficiency anemia with colon cancer. But once you get the initial test, at my end, I would probably refer to the appropriate specialist.
Yeah, but how do you manage? Suppose he has 2 ailments. He has a gynecological problem and also has cancer. So
I'm a pediatrician, so I would have to defer that to the gynecologist. I think you had Dr. Bright here. Maybe in Nigeria they do it a different way, but here in the United States, everyone kind of practices in their own. We know generally things that, just like I know a bit about colon cancer just from being a physician, but in terms of giving the best care to the patient, it's important to refer out.
Everyone stay on their lane. Well, I mean, it's been a nice show.
Tatagoa, we have to come back to you. Now that we're almost running up this program, there are a lot of patients who had suffered from cancer and they are still experiencing some complications. Are there complications that normally arise at the end of treatment? Do you have lingering complications, lingering symptoms, or can one be completely free? Are there permanent damages? that one can experience. I met a cancer patient, and I didn't like her looks, even though she's a survivor, but her looks was not good. So
this is a very good. Actually, this is a very good question because, yes, the colon cancer. So there are two things. One is the complications from surgery, and then complications from chemotherapy. Okay, so the complications from surgery in the good hands for the colon cancer, it should be minimal. These days, it's all laparoscopic surgery. We don't make huge, big incisions. We don't have to cut a lot of nerves. And laparoscopic surgery is very minimally invasive. When I used to be a surgeon like 30 years ago in India, the dictum or the main principle of surgery was open up as big as you can, open the belly, we go and cut it from xiphoid cartilage all the way to the pubis so you can look around the whole belly. And then you used to see big, huge scars, ugly scars, keloids, complications from surgery all the time. But these days with laparoscopic surgery, I think the complications for surgery should be very, very minimal. Chemotherapy, yes. Chemotherapy has a lot of sometimes lingering side effects which can go on for years. The biggest one is some people have even talked about chemotherapy brain, that it affects your brain in a way that your cognitive ability, you lose some of your cognitive ability over times with chemotherapy. But this is only for the stage 3 and 4 cancers. Stage 1 and 2, most of the time, they don't need this thing.
Okay. Dr. Fatrigo, just one more question.
So
we have people suffering from diabetes.
So
suffering from diabetes, chronic diseases, suffering from hypertension. So how does this impact cancer?
So that should not be any impact on the management of diabetes, hypertension, heart disease, anything from the treatment of colon cancer or from the chemotherapy. Once you've gone through the chemotherapy, adjuvant chemotherapy, it should not affect in any possible way. One of the things I do tell my patients, all the patients actually, I tell them for all the cancers, especially for the colon cancer and the breast cancer, is the most important thing is still in colon cancer prevention and preventing the complications is physical activity. And in large meta-analysis, big analysis, it has been shown that if there is a physical activity and if they exercise regularly, the colon cancer risk can be reduced by 26 to 27% over a long period of time just by exercising. I mean, you don't need a pill, you don't need anything, just by you're reducing the risk by almost a 25% chance. It is almost as big of a risk reduction as much as taking a non-steroidal or an aspirin. There is some data that aspirin and non-steroidals, if you take on a regular basis, it reduces the chance of colon cancer. So, I mean, even post-operatively or post-chemo, I tell them to exercise. And the second most important thing I tell them is they have to go on a very high-fiber diet. I mean, one of the things I take myself, Metamucil, on a very regular basis, is a high-fiber diet will prevent a lot of these complications, including related to diabetes and hypertension. Exercise and diet. This should be the main message from this talk.
I would agree.
But once you have colon cancer, we have very good curative options.
Dr. Fatrigo, you wanted to say something?
No, I was agreeing with Dr. Agrawal. Exercise, especially in Western societies, we become lazy. Everything is about our screen time, whether it be our phone or our tablets. We don't go out and play. At least the kids I see don't go out and play as much as they used to. We can increase our exercise and watch what we eat, more fruits and vegetables. That in and of itself, if you stay away from smoking, stay away from alcohol, which you should in the pediatric population anyway. If you take those risk factors out, your odds of getting cancer actually, it's not impossible, but you reduce the risk dramatically.
Okay.
What you eat and staying away from vices.
Wow. What another wonderful sessions at Keyna Health Show. As usual, we normally drop what we call just the elevator speech, like within 1 minute. If you want to summarize what has been covered today, or maybe somebody is just joining us or somebody has joined us and you want that person to just go home. So we call it a take home. So what would that be? Let me start with Dr. Agbola Fatire. Over to you, sir.
So the Black Panther, Chadwick Boseman, he was pretty fit. He had everything going for him, yet he died of colon cancer not too long ago. It's really real. It's something that we should keep at top of mind, no matter what age group you are. When you're seeing me, definitely, and parents are bringing their kids to me, definitely try to. I know kids can be tough at times, but let's try to implement more good nutritional values and getting them to exercise more and more to help prevent. And as you become an adult, watch the amount of alcohol intake, and then see your primary care provider once a year so that you can follow those screenings.
Awesome. Thank you so much. Over to you, Dr. Agaro.
So still that was very nice, Dr. Agbula, and I heard about that story also, and I feel sad when I see patients dying of colon cancer, and the fact is, about 50 to 51,000 people will die of colon cancer in US this year. It's still even though the death rate is going down, and the cure rate is obviously going up with the colon cancer, but still. Looking at the kind of preventable disease and the treatable disease it is, still we see about 50 to 51,000 death a year from colon cancer, which is still kind of a little bit a shame. Like Dr. Agbula said, I strongly recommend exercise and diet. There are certain other things you can do. Take aspirin, some non-steroidals. There are some other things like B6 vitamin, calcium in high-risk population. They can try that. But see your doctor, and colon cancer is a very preventable disease and curable disease.
Thank you so much. Thank you so much. So
just I got my colonoscopy, just to tell you, I just got my second colonoscopy 2 months ago. So
that's good.
I got my first one last year when I turned 50.
And I'm planning mine for this year. Okay, Mr. Alex.
Yeah, I stand with the two doctors to advocate for high fiber diet, exercises, and medical attention.
Yes. I know that we've covered, and I know we just gave our elevator speech, like this man that I went to see yesterday. After we talk, we discuss what is going on with my own personal life. We discuss what is going on. So when we were about to leave, say, okay, yeah, Pastor Dubia, let me ask you. So when was the last time you did your lab? Your HANA? I said, well, we did 2 years ago. My wife quickly corrected. No, I said last year. My wife quickly corrected me. Said that was 2 years ago. So the man said, okay, make sure you
trying to lie.
So make sure you do it. And when you go, precisely ask your doctor that you want your PSA to be done. So make sure it's not just good enough to say, oh, this was a good show. Make sure you do what you need to do. Look at all what we've discussed. Early catch, early detection. That is a lot easy to deal with. By the way, my name is Emmanuel Adigbola. Once again, thank you so much for connecting with us. Over to you, Dr. Keyna, as we round out the show.
Wow, what another wonderful show. I want to thank Dr. Agarwal and Dr. Fatiregu for representing as always, and always honoring our invitation to bring a lot of information to our viewers. So today we visited again with colorectal cancer and how it can be prevented. My husband died 9 years ago, last month, from colon cancer. He shouldn't have to have died if we took the necessary steps. So that's the reason that I'm bringing this show to you, to talk to you from the first hand of someone who lost a loved one to a cancer that is so preventable. So I also want to talk to parents. I know you love your kids, and I know you want to give them McDonald's. I know you want to give them fast food. You want to give them fruit juices, but you're not doing any good to them. It is not too early to start cultivating those good habits of eating and exercising in the right way, the right manner, so that these diseases can be prevented, from obesity to blood pressure to diabetes to cancer. It is preventable, and it's all about what you eat and whether you exercise or not. Join us again in the next few weeks for another wonderful show. Thank you all.